Whatever you think, so will you be. If you think yourself to be weak, weak will you be. If you think yourself to be strong, strong will you be. So, yes, this is not just a quote. Every word of this quote is 100% true. Let us take a small example. Yes, now just imagine you have a lemon in your hand. Yes, you cut the lemon, bring the lemon close to your mouth. Yes, open your mouth, pour the lemon in your mouth. Did you start salivating? Yes. Where's the lemon? Is there any lemon in your hand? Is there any lemon around? Can you smell the lemon? Nothing. But still, you started salivating. Your body responded to what you thought. So each thought is a blow on your mind. It is like a hammer which blows, which changes your mind, changes your body. So the first step, if you want to succeed, is to believe that you can succeed. And you have to train your mind to think so, be it night, be it morning, be it evening. Every moment you have to think that you will succeed. You want to be, if you want to be within the first 50, if you want to be within the first 100, you have to think first. You have to believe first that you will do it. You have to tell it to yourself. You have to keep that in your mind till each and every part of your body, your nerves, your muscles resonate with that thought. That is the only way to success. So if you want to succeed, keep that thought, keep telling yourself that to yourself each and every second. So with that thought always in our mind, now let us start with the embryology of the external and the middle ears. Now, we have already done the embryology of the inner ear. The pattern that the sequence that I followed in these modules is how you have to follow it. Many of the times you don't see embryology of the inner ear and you just jump on anatomy of the inner ear. Most of the things we are doing clinically. When we are doing embryology of the external ear, we are doing a lot of clinical things also along with that. So when we are doing embryology of the inner ear, like we have done in the previous module, you have also seen that we have done a lot of clinical aspects also, a lot of anatomy also. So please follow the pattern that these lectures have been taken, especially the anatomy and the testing part, the audiology part. Now we know that in the neck of the developing fetus develop 6 branchial arches. Yes. Now out of which one disappears? The 5th disappears. So we are left ultimately only with 5 branchial arches. Now each arch has the ectodermal lining on the outside. Yes, and it has an endodermal lining on the inside. The ectodermal lining on the outside dips. This dip is what is known as ectodermal cleft. Yes, and where the endoderm dips this here, this is what is known as endodermal pouch, which means that if we say that something is developing from the cleft, it is ectodermal, endodermal or mesodermal. Yes, it is ectodermal. If something is developing from the pouch, it is endodermal. And if I say it is developing from the arch, then that is mesodermal. Yes, this inside is the arch, and this is the mesoderm. So around the first cleft, from the first and from the second arches, develop 6 mesodermal thickenings. As you're seeing here, this is the cleft part that we are seeing, the first cleft. Around the first cleft, develop from the first arch and from the second arch 6 mesodermal thickenings. So these are from the first arch and these are from the second arch. From the second arch. So these mesodermal thickenings are what are known as hillocks of His. Hillocks of His. These hillocks fuse to form the pinna. So these hillocks from the 2 arches, these how many hillocks? 6 hillocks from the 2 arches. Which 2 arches? First and second arches. They fuse to form a single framework of cartilage. So this pinna cartilage that you're seeing, it is one framework of cartilage, and this develops from the 6 hillocks from the first and second arch. Now which part develops from which arch? So this is what is the tragus, and this develops from the first arch. So the tragus develops from first arch. Some books also consider that tragus and some part of the helix. This part of the helix, this is what is known as the ascending crust of the helix. This also develops from the first arch. The rest of the pinna develops from the second arch. from the second arch. So this is how the pinna develops. So whenever there is any fusion defect of the auricular tubercles of the hillocks, then this can lead to the formation of a sinus. Most common location of the sinus is in front or and just above the tragus. This is what is known as preauricular sinus. Preauricular sinus. And yes, this is a question of your exams. What is preauricular sinus an abnormality of? Yes, it is the fusion defect of the hillocks office of the auricular tubercles. And again, what is asked is, what is the most common site of the preauricular sinus? Yes, the most common site is at the root of helix. So the most common site is at the root of helix. Root of helix. Okay, now abnormality of the fusion of these hillocks can also lead to accessory appendages. As you can see here in front of the pinna, you can see so many appendages. These are known as preauricular tags. These are known as preauricular tags. There can be multiple abnormalities of the pinna. These are the some which are asked in your exams. So here the pinna can be absolutely totally absent, which is known as a nausea. This is totally absent pinna. Absent pinna. Yes, or it can be deformed. It can be a small pinna that you are seeing. Only some parts are developed, which is known as microtia. Microtia. Do you think that if there is any nausea or if there is any microtia, suppose this child, will this child have a hearing loss? Yes or no? Of course, the child will have a hearing loss. What should we do? We know hearing is very, very important for children. It is important for the language development, for their learning. So we cannot leave this child with a hearing loss. What should we do? Should we go for a cochlear implant? Cochlear implant? We did in the previous section. Cochlear implant replaces what? Yes, replaces the organ of Corti. It is given when the organ of Corti is defective. Is the organ of Corti defective in this child? No. Where's the defect? External defect. So there is an external defect. No, cochlear implant won't help. We are not going to go for a cochlear implant. Then what should we do? Yes, should we go for a hearing aid? We have seen how a hearing aid looks like. This is something like the Bluetooth that we put into the ear. This is the in the canal hearing aid. Can we go for this hearing aid? Behind the ear hearing aid? Yes, hearing aid can come in various forms. So can we go for a hearing aid? Look at the pinna of this child. Yes, can you see the external auditory canal? There is atresia of the external auditory canal. The pinna. So where is the child going to put this type of hearing aid? Not possible. How is the child going to put this type of hearing aid which has to have support on the pinna in this type of pinna? Not at all possible. So if we want to give hearing rehabilitation for this child, we will have to give a hearing aid which anchors to the bone behind the pinna. And this is what is known as bone anchored hearing aid. A very important question of your exam. Bone anchored hearing aid. Bone anchored hearing aid. It is a hearing aid which is anchored to the bone behind the pinna. And what is asked in your exam is that what is the mode of hearing rehabilitation which is given in external deformities of the ear? Yes, so whenever there is any external deformity of the ear, we can go for BAHA, bone anchored hearing aid. What is this? Is this a hearing aid? Is this BAHA? No, it has some part like a hearing aid and it has some part this. Yes, what is this? This is how a cochlear implant looks like. Cochlear implant is a no-no in this condition. We will do in detail cochlear implant later on. But this is just to give you a glimpse of how the cochlear implant looks like. Anyway, the indication is also not of the cochlear implant here. So the parents have got this child to you and they're very troubled. They are telling you that, doctor, please do something for our child. And what you're telling them is that, okay, I will give him a BAHA, a bone anchored hearing aid. The child will be able to hear. Now the parents tell you that, no, doctor, we do not want that. What we want is that you repair this deformity. This is going to be a very bad cosmetic deformity. Why don't you repair it? Once you repair it, hearing will automatically come back to normal. Yes or no? So can you repair this pinna also? Yes, we can. That is a cosmetic surgery. It is done in stages, not before 6 to 7 to 8 years of age. So there it is again done in stages. It is highly expensive. So if parents can afford, if they are willing, you can go for repair of the external ear. And this cosmetic repair of external ear, do you know what it is known as? It is known as otoplasty, or it is known as pinnaplasty. Now here what you need to know is that when we need to reconstruct the pinna is cartilaginous, so we will reconstruct it with the help of cartilage. From where are we going to bring that cartilage? Yes, from the child's rib cartilage. It is autologous rib cartilage. So that is a question that is asked. It is autologous rib cartilage. Rib cartilage that is used to reconstruct the pinna. And the second thing that is asked here is that reconstruction of the pinna cannot be done before what age? Yes, it is not done before 6 years of age. So it has to be done only after 6 years of age. Only after 6 years of age, any reconstruction of the pinna can be done. Why not? Why not before that? When we anyway have to do it? Yes, because the rib cartilage is not well developed enough that a graft can be taken from the rib cartilage before 6 years of age. So these both are questions that are asked in your exam. So just let us see this. Yes, this is how the costal rib cartilage graft is taken, and that is reformed in the shape of this pinna framework, and this is implanted in the place of the pinna. So that is what we need to know in the development of the pinna. So keep your pens down. Yes, straight, sit straight. Yes. So tell me quickly, pinna develops from which arches? Pinna develops from first and second arch. Which part of the pinna develops from first arch? Yes, the tragus. Rest of the pinna develops from the second arch. A fusion defect of the auricular tubercles leads to the formation of preauricular sinus. Yes, if there is any microtia or anotia, what can be the hearing rehabilitation you can give to the child? Cochlear implant? Yes, no. A hearing aid, normal conventional hearing aid? Yes, no. No. No cochlear implant, no conventional hearing aid. Then tell me the answer. Yes, it is BAHA. What is BAHA? Bone anchored hearing aid. Yes, how many auricular tubercles lead to the formation of the pinna? Yes, 6. What are they known as? Hillocks of His. Yes, reconstruction of pinna cannot be done before what age? 6 years of age. It is done with the help of what cartilage? Rib cartilage. Rib cartilage from where? Yes, the child's. What is that known as? Autologous rib cartilage. So now that we have done with the anatomy of the pinna, let us see how the external auditory canal develops. So here we know we have the first arch, we have the second arch. In between them, this is known as the cleft. The ectodermal lining dips inside to form the cleft. Yes. So this cleft, it grows medially, and this cleft leads to the formation of external auditory canal. As you can see here, this cleft is growing inside medially, and this leads to the formation of external auditory canal. So the external auditory canal develops from first cleft. Develops from first cleft. Now here we need to know a very important thing, that at birth it is only the cartilaginous part of external auditory canal that is present. So yes, the external auditory canal has two parts, cartilaginous and bony. It is only the cartilaginous part which is present at birth. The bony part develops later on. How are we going to remember that? Is the pinna present in infants at birth? Yes or no? What are you thinking? Yes, it is present. So pinna is cartilaginous or bony? Yes, cartilaginous. So cartilaginous part of the external auditory canal is extension of the cartilage of the pinna. Along with the pinna, the cartilaginous part is present. The bony part develops later on. So yes, we can see here the external auditory canal. This is the cartilaginous part. This is present. The bony part will develop later on. The cartilaginous part is present along with the pinna, so it is outer. The bony part is inner part that will develop later on. So this is the other thing that we need to know, that at birth, present is cartilaginous part, and not completely developed, not developed completely is the bony part. Now here another thing that is asked in your exam is that the external auditory canal, the canal develops from the cleft, whereas the meatus, now this is a new update. The meatus, what is the meatus? It is the external opening, the opening, that is the external acoustic meatus. This was believed to develop from the cleft, from the first cleft, but now it is believed to develop from the first arch. From the first arch. So it is said that the tragal cartilage, the cartilage, that itself forms the external acoustic meatus. Tragal cartilage is from first arch? Yes or no? Yes, that itself forms the external acoustic meatus, and the canal develops from the first cleft. It is a first cleft derivative. So we know that all these clefts and arches are present in the neck of the fetus, and then the first cleft, it grows medially, and this leads to the formation of the external aortic canal. And after the external aortic canal has formed, this ventral part of this cleft, it disappears. It disappears. Yes. Now, if it persists, then this can lead to the formation of a communication between the neck and the external aortic canal. This is what is known as call oral fistula. This is known as call oral fistula. And what we need to know in call oral fistula, first, it is a abnormality of first cleft. First cleft. And second, since it is a fistula, fistula will have two openings. So where are the two openings? So that is the other question that is asked here. Yes, the first opening, this is the first opening, that's the external opening. This is present in between the angle of mandible, and here we have the sternocleidomastoid muscle. So this is the first opening, external opening, and the second internal opening of the fistula, that is present in the internal opening, is present in the floor of external auditory canal. Floor of external auditory canal. So if it is just present like a sinus, you are not doing anything, you can just leave it. But if it is recurrently getting infected, discharging, and that is causing pain and discomfort to the patient, then in that case, we need to excise it. So when you need to excise it, you need to remember that this tract, this cleft, the remnant of the cleft, passes from the neck into the external auditory canal, and on its way, it passes through the parotid. What's the significance here? The facial nerve also passes through the parotid. Yes. So this tract lies in very close relation to the facial nerve. So you have to be very careful. You don't have to remove the tract and following surgery give a facial nerve palsy. That would be worse. Yes. So you have to remember that it is in close relation to the facial nerve. The call oral fistula. So that is what we need to know in the development of the external auditory canal. So quickly tell me, external auditory canal develops from, yes, from the first cleft. That is very easy to remember. What is the cleft-like structure of the ear? Cleft. Yes, it is going inside like a cleft. What is that? The external auditory canal. So the cleft of the ear develops from the first cleft. That is the external auditory canal. Which part of the external auditory canal is present at birth? Cartilaginous or bony? Yes, the cartilaginous part. What is abnormality or persistence of a part of the first cleft known as? Yes, the call oral fistula. Where's the external opening of the call oral fistula? In between. Show me in your face. Yes, where is that? Yes, that is in between the angle of mandible and sternocleidomastoid muscle here. Where's the internal opening? Floor of external auditory canal. It is in very close relation to which nerve? Facial nerve. So coming to the development of the middle ear. Now what we saw is that the first cleft is growing medially, and this is leading to the formation of the external auditory canal. At the same time, the first pouch, here this also starts growing medially, and it goes and meets the cleft. Is that clear? Yes. So what does this form? What lies medial to the external auditory canal? If the cleft is forming the external auditory canal, medial to that is a pouch. What will that lead to the formation of? Yes, the middle ear. So the middle ear develops from the first pouch. How will you remember that? How you remember the external auditory canal? External auditory canal is like a cleft. It is developing from the cleft. How you will remember that the middle ear develops from the pouch? Middle ear is a pouch containing ossicles. Yes. So like that, remember that middle ear develops from the first pouch. Now the middle ear, when the first pouch grows laterally towards the external auditory canal. So this is what is known as the tubotympanic recess. Tubotympanic recess, and this name tells you what the first pouch is leading to the development of. So tubotympanic recess is another name for first pouch, and this tells you it leads to the formation of tubo. What is tubo? Tubo is eustachian tube. Eustachian tube, and tympanic recess is tympanic cavity, that is the middle ear cavity along with the mastoid. Let me draw this and show you. So this here is the tubotympanic recess forming the eustachian tube. Here we have the middle ear cavity, and the mastoid. Mastoid. Yes. So what is the mastoid? What is mastoid? Antrum. This is the mastoid antrum. What is mastoid antrum? It is the largest mastoid hair cell. In the mastoid bone, we have multiple hair cells. The largest mastoid hair cell is what is known as mastoid antrum. That develops along with the middle ear from the first pouch, and together the eustachian tube, the middle ear and the mastoid antrum is known as middle ear cleft. So when it is asked middle ear cleft develops from, don't think okay there is a cleft in the question, so in the answer also it will be from the first cleft. Does the middle ear cleft develop from the first cleft? No. What is middle ear? Middle ear cleft. Middle ear cleft is the middle ear along with its connections medially and laterally. Along with its connection to the pharynx, that is the eustachian tube, and along with the connection posteriorly to the mastoid antrum. So together this develops from the tubotympanic recess, and that is the first pouch. So yes, it is asked, what is middle ear cleft? Now when this first pouch is developing medially to form the middle ear cleft, it also encompasses the mesoderm from the first and the second arch. We know that these arches, in between them is the cleft and the pouch. So from the first and the second arch, it encompasses some, it grabs some of the mesoderm, and what this does is this leads to the formation of the ossicle. So here inside the middle ear develops ossicles from the first and second arch. From the first arch develop the malleus and the incus. This here is the malleus and this is the incus. So from the first arch develop the malleus and the incus, and from the second arch develops the stapes suprastructure, not the complete stapes, it is only the stapes suprastructure. Suprastructure. So not the complete stapes, only suprastructure. What does that mean? So yes, stapes has a head, it has got a neck, it has got two crura, anterior crura and posterior crura, and it has got a foot plate. Yes, so this complete head, neck, anterior and posterior crura is what is known as the suprastructure. The foot plate then does not develop from the second arch. Foot plate develops from where? We did that, yes, in the previous module, in the ear, inner ear. Yes, the foot plate is present where? The foot plate is present on the oval window. The foot plate is present on the oval window, which is the connection between the middle ear and inner ear. Yes, so oval window is the opening in the bony labyrinth. It is covered by foot plate. Foot plate is also a derivative of the bony labyrinth. So the foot plate develops from bony labyrinth. Sometimes in your exam, bony labyrinth is not then the choice. What is given? Otic capsule. What is otic capsule? Otic capsule is another name for bony labyrinth. Now, when this cleft is growing medially and when the pouch is growing laterally, yes, just see here, the cleft is growing medially and the pouch is growing laterally to form the middle ear. Where they meet, this area forms the tympanic membrane. Tympanic membrane. So, what we know is that the tympanic membrane has how many layers? Yes, it is developing from three parts. The outer part, it has three layers. It has three layers. Yes, the outermost layer is developing from the ectoderm, from the cleft, ectodermal cleft. Yes, the middle layer in between this one, this is the mesoderm that has got entrapped. So the middle layer is the mesoderm, and the inner layer is the same as the middle layer, and that is the endoderm. Endoderm. We know that the pouch is endoderm. Yes, the pouch is endoderm. Okay, so now quickly you are going to tell me, yes, the ear has how many parts? The ear has three parts: external ear, the middle ear, the inner ear. Yes. So now tell me, in the external ear, we'll start from the outside. Yes, pinna develops from where? Pinna develops from, yes, the six hillocks. Which arches? First and second arch. Yes, go more medially. External aortic canal develops from first cleft. External acoustic meatus develops from first arch. Which part of external aortic canal is present at birth? Present at birth, cartilaginous part. Develops later on is the bony part. Okay, coming to the tympanic membrane, more medial tympanic membrane develops from, yes, from all the three layers of embryonic. It has got how many layers? Three layers. Go more medial, yes, that is middle ear. Middle ear develops from, yes, from the first pouch. What is the first pouch known as? tympanic recess. Middle ear cleft develops from. Middle ear cleft develops from first pouch. And what is middle ear cleft? What exactly is this formed by? Yes, this is the eustachian tube, the middle ear cavity, and the mastoid antrum. What is mastoid antrum? The largest mastoid air cell. Was a question asked in your exam. The proximal part of the tubotympanic recess leads to the formation of. Yes, proximal part is what? Proximal part is the one that is towards the midline. Distal part is the one that forms, that is away from the midline, that forms the middle ear cavity and the mastoid antrum. So proximal part leads to the formation of is the eustachian tube. And if it is asked the distal most part of the middle ear of the tubotympanic recess leads to the development of, what will be the answer? Yes, the mastoid antrum. Reconstruction of pinna is not done before what age? Not done before 6 years of age. It is done with what? With rib cartilage. Very good. With rib cartilage. And if there is abnormality of the pinna, there is microtia, there is anosmia. Rehabilitation of hearing can be by BAHA, bone anchored hearing aid. Now, where is the mastoid? Yes, this here is the mastoid. This is the mastoid here. This develops from outside. This is the squamous part of the temporal bone. This extends to form the outer part of the mastoid, and the inner part of the mastoid is formed by the petrous part of temporal bone. So here this area is the mastoid. Superficially it is formed by the squamous part, and deep part is formed by the petrous part of the temporal bone. So when we take a cut section like this, yes, what is this cut section known as? A coronal cut section. This is how the mastoid will look like. This is the lateral part, that is the skin. So this is the skin surface, and as we go medially, this is, we are going deeper. So this is formed by the outer part is formed by the squamous part. This is the squamous part, and in the inner part, the deep part is formed by the petrous part. Now, where these two meet, where the squamous and the petrous part meet, forms a suture. This suture is known as petrosquamosal suture. This is also known as the very, very commonly asked in your exam, Corner's septum. This is known as Corner's septum. What is asked in your exam is two things. First, what is Corner's septum? So it is petrosquamosal suture. And second, what is asked is, what is the significance of Corner's septum? If at all this suture is present, how is it significant to us? Yes, now just listen to this very carefully, understand this. Now, when we know that in the mastoid, there are multiple air cells. Yes, the largest mastoid air cell is present in the petrous part, and this is known as mastoid antrum. Whenever there is any disease of the mastoid, the maximum disease lies in the mastoid antrum. So whenever we operate on the mastoid, our aim is to remove, to clear all the disease from the mastoid antrum. So what we do is, the surgeon starts drilling. Okay, so now he starts drilling. How is the drilling done? For now, you can just remember like how we drill a hole in the wall. Yes, so we have a very sharp drill which moves at a very high speed, and the bone is removed. So we start drilling, the surgeon starts drilling, and he goes on drilling. As he goes on drilling, the air cells start opening, and all the disease from the air cells he goes on removing. Now suppose this corner septum is present. This surgeon confuses this corner septum with this. What is this? This is the medial most wall of the antrum. What lies medial to this? Just imagine you are drilling here. Yes, you have started drilling the mastoid. You go on going deep. You reach the antrum. If you go further medially, will you not enter into the posterior cranial fossa? Yes, just see here. You start drilling, and when you go on drilling inside, if you go further medial to the mastoid antrum also, you will be into the posterior cranial fossa. That is what we do not want. When we are removing disease of the mastoid antrum, we want to limit our surgery up till here. So now what happens if there is a persistence of the petrosquamosal suture? The surgeon thinks that this is the medial most wall of the antrum. He feels that this is where he has to stop the surgery, and he stops the surgery here. So if he has stopped the surgery here, what will happen? Has he cleared the disease from the mastoid antrum? Has he served the purpose for which he operated? No. So this persistence of petrosquamosal suture, what is the significance? It leads to incomplete clearance of disease from mastoid antrum. And also we know here that the mastoid antrum develops from superficial Yes, superficially is the squamous part and deep is the vitreous part. So do you know of any part of the ear which is not present at birth? Yes, you tell me one, I will tell you another. I have already told you one. Yes, the bony part of external auditory canal. Yes, the other is mastoid tip develops at 2 years of age. Develops at 2 years of age. Yes, so just have a look at this fetal skull. Here all the muscles and the cartilages have been removed. So the pinna has been removed. And when the pinna has been removed, can you see the pinna cartilage and the external auditory canal cartilage are in continuity. So that also has come out along with the pinna cartilage. So what we can see is just there is a tympanic membrane. Can you notice this? Yes, so the external auditory canal, bony part of the external auditory canal is so less well developed. Another part, just notice here, the mastoid tip, can you see it is missing? Yes, the mastoid bone is there. The mastoid antrum, what do you think, it is present or not? Mastoid antrum was developing along with the middle ear. That was a part of the middle ear cleft that was developing with the help of, it was developing from what? Can you tell me? Yes, the pouch. So that is present. The largest mastoid hair cell is present, but mastoid is not only the mastoid antrum. It is all the mastoid hair cells. So the complete mastoid is not developed. Which part is not developed specifically? Yes, the mastoid tip. The tip of the mastoid is not present at birth. In fact, what you have to remember, very simple to remember, is it is only the external parts of the ear which are not completely developed at birth. The inner parts of the ear, that is the middle ear, the inner ear, they are completely developed at birth. If I tell you ossicles, are they completely developed at birth? Yes or no? Middle ear? Yes, it is completely developed. The inner ear, the organ of Cotta, is it completely developed at birth? Yes or no? Yes, it is completely developed at birth. In fact, it has been asked in your exam that inner ear or organ of Cotta is completely developed at how many weeks, so that a fetus can start hearing in intrauterine life itself. Yes, it can start hearing fluid bone sounds. Yes, you must have heard that Mahabharat story where Abhimanyu heard everything when he was in the womb of the mother. Is that true? Yes. A fetus can hear. A fetus can hear fluid bone sounds from about 20 weeks. So all the middle ear, the inner ear, they are completely developed. Completely developed at birth. Yes, also the organ of Cotta which is present in the inner ear, it is asked, it completely developed at 20 weeks. At 20 weeks. So which are the parts which are not completely developed? So in not completely developed, we have the not completely developed. Yes, you told me one. What was that? That was the bony external auditory canal. So what is the significance if the bony external auditory canal is not completely developed at birth? Yes, we can see that just after the cartilaginous external auditory canal, we will have the tympanic membrane. So the external auditory canal will be so short. So which means that the injury of the tympanic membrane will be very, very easy if you're not careful. Yes, which means if the parents think that there is something which has gone, the foreign body has gone inside and they want to remove it, then tympanic membrane, there are high likely chances that it can get injured because the external auditory canal is very short. And another is the mastoid tip. The mastoid tip develops at 2 years of age. Mastoid tip develops at 2 years of age. Yes, what's the significance? Now just see, this is the adult temporal bone. This is the adult ear skull. So what we are seeing here is, this is the external auditory canal. We can see that this whole external auditory canal, this length of external auditory canal, this is present here. Whereas in the child, what was there? The tympanic membrane was immediately present. We could see the tympanic membrane in the skull. Here in the skull, what we are seeing is the bony external auditory canal. Yes, after the cartilaginous has been removed. And what we are seeing here is the mastoid tip. Mastoid tip, why does it develop? Why it is not present at birth? Then how does it develop later on? Yes, at the mastoid tip area, two muscles are attached. Which two muscles? Yes, the sternocleidomastoid and the posterior valley of digastric. So as the child learns how to hold his head, because of the pull of these muscles, develop the mastoid tip. So this is very, very useful for us, the development of mastoid tip. Why? Because just below the mastoid tip, we have the foramen. Which foramen? Yes, the stylomastoid foramen, through which what comes out is the facial nerve, which means in all of us, where is the stylomastoid foramen? It is protected below the mastoid tip. Whereas in an infant less than 2 years of age, can you see here? There is no mastoid tip. So we can see this foramen here, the stylomastoid foramen. So what? So the facial nerve, when it is coming out, it is not protected by the tip as it is here. Here it is protected by the tip. Yes, whereas here it is not protected by the tip, which means that it just behind the ear at the level of the stylomastoid foramen, the facial nerve is lying just below the skin. Just below the skin. So here is a child who has come to you with a post-auricular abscess and you want to drain this abscess. Tell me, where will you give the incision? Yes, should you give the incision inferior and vertical, or should you give the incision superior and horizontal? What have you chosen? Yes, I knew you will choose the correct. Yes, this is the inferior and vertical. This will never be chosen. What you will choose is a superior and horizontal. Superior and horizontal. Yes, why have you not chosen this? Why not chosen this? Yes, because you know that in this child, the facial nerve as it is coming out will be lying just below the skin. So if you give an inferior and vertical incision, that will cut the facial nerve and give the child a lifelong facial palsy. So that is why you need to know that the mastoid tip develops at what age? Yes, it develops at 2 years of age. Any incision, post-oral incision before that has to be superior and horizontal. Okay, so now quickly you're going to tell me which are the parts of the ear which is not completely developed at birth. Not completely developed at birth. Mastoid tip, yes or no? Developed, not developed? Not developed. Developed at what age? 2 years of age. Mastoid antrum, developed, not developed? Mastoid antrum, completely developed at birth. Mastoid antrum develops from? Yes, from tubotympanic recess. That is first pouch. Tell me the first arch derivatives of the ear. First arch derivatives of the ear. Everything that you know from the first arch in the ear. Yes, very good. Tragus. Anything else? Yes, the malleus and the incus. Tell me the second arch derivatives of the ear. Second arch derivatives? Yes, the whole of the pinna other than the tragus. And anything else? Yes, the stapes. Which part of the stapes? Yes, the stapes. Suprastructure. The footprint of stapes develops from? From bony labyrinth. From otic capsule. External otic canal develops from first cleft. The first pouch derivative of the ear is first pouch. Pouch. Yes. Yes, that is the middle ear. Tympanic membrane develops from? All the 3 layers of embryonic disc. Yes, a fusion defect of the auricular tubercles of the pinna leads to the formation of preauricular sinus. What's the most common site of preauricular sinus? Yes, it is at the root of the helix. Yes, that's the root of the helix. Which are the parts of the ear which are present at birth? Ossicles, present, not present? Present at birth. Organ of Cotta is completely developed at what age that a child can start hearing in intrauterine life itself? Around 20 weeks. Around 20 weeks. So that is what we need to know in the development of the ear. So quickly open your questions and finish them off.